Hi, my name is Anai Hygenes, and I will explain my case study development with my patient. My patient, he is a 55 years old man. He's Hispanic, and he and his wife smoke since they were 18 years old. They used to smoke one pack every day. In addition, they smoke more when they drink coffee. My patient moved to the United States 10 years ago with his wife and his children. They live in Riverview since they arrived here in a low income apartment. He used to work in a factory doing frames, but he stopped working when he was diagnosed with lung cancer in November of 2014. He was disabilitated because of his condition. However, his wife continued smoking until now. My patient has lung cancer and stem cell transplant, and we have some special consideration in dental office for this kind of patient, such as have a dental cleaning right before the next chemotherapy, time oral surgery to allow at least 2 weeks for healing before radiation therapy begins, have the oncology team conduct blood work 24 hours before dental treatment to determine whether the patient platelet count, chlorine factor, and absolute neutrophil count are sufficient to recommend oral treatment. And if not, we postpone oral surgery or other oral invasive procedure. There is no allergy, and the vitals taken were blood pressure 130 over 85, pulse rate is 60, respiration rate is 12, and temperature is 98.7. He is a class 4 ASA, and he has surgery of the third molars removed in 1990. He has a hospitalization for chemotherapy for lung cancer treatment in 2015 and a stem cell transplant in November of 2015. He's also taking two medications for condition and disease, which are Tretsol that he started in 2015 and filgrastim started in the same year. We also need to be aware of um, possible emergency associated with patient condition, and we have to administer oxygen or monitor vital signs and call 911 in case of an emergency with this patient. I find some oral conditions, which are xerostomia, oral mucositis, trismus, rampart, caries in teeth number 3, 4, 5, 18, 19, 28, and 23, candidiasis infection in vocal mucosa and tongue, and patient present a herpetic lesion on the facial of 6 and 11, and generalized moderate periodontitis with a localized severe periodontitis in posterior region. So these are the two medications the patient is taking right now. The dosage for Tretsol is 7.5 milligram once weekly, and for filgrastim is 10 mcg. They giving us an intravenous infusion of 4 or 24-hour or as a continuous 24-hour subcutaneous infusion. Here are some special considerations when taking this medication, which are can cause drowsiness, dizziness, or blurred vision. Also, contraindication of medication and the oral effect of medication, which can be stomatitis, gingivitis, glossitis, and mucositis, and mouth ulcerations. So this is an overview of the um, use of this medication with the contraindication, consideration, and the oral finding that or side effect that this medication can produce. I did an extraoral and intraoral exam, and he present baldness and pale color skin, also inflamed lymph nodes with trismus. His lips were dryness with pale color, and I found a herpes labiali in the lower lip. On the mucosa, He had candidiasis infection in the buccal mucosa and 6/7 ulcer in the left side of the labial mucosa. He also has petechiae in the soft palate caused by smoking, and his tongue is covered with candidiasis infection. He also has mandibular tori with oral mucositis under the tongue. He presents generalized moderate calculus with localized heavy calculus in the lower anterior and generalized moderate plaque with a PI of 80%. He presents generalized heavy stain and a generalized heavy bleeding on probing. On the dental shading, patient presents generalized 4 to 6 millimeter pocket with a localized 7 to 8 millimeter pockets in teeth number 2, 3, 14, 18, and 19. Also generalized 5 to 7 millimeter of clinical attachment loss with a localized of 8 to 9 millimeters in teeth number 2, 14, and 19. Generalized 1 to 3 millimeter of recession, and he has restorative um, PFM crown in tooth number 3. He is missing teeth number 1, 15, 16, 17, and 32, and he has caries in teeth number 3, 4, 5, 18, 19, 23, and 28. He has oral lesion of candidiasis infection in the buccal mucosa and tongue, and herpetic lesion on the facial of 6 and 11. On the gingival assessment, patient presents with a generalized moderate bright red distributed marginal papillary to diffuse. Gingiva appears with a generalized flatness and crater on the margin region due to recession and abrasion in the area, and a localized bulbous on the interdental papilla of anterior teeth from 22 to 27, including areas of pseudopocket with evidence of recession as well. Generalized recession of 2 to 4 millimeters. Consistency presents a generalized alteration of a severe marginal fibrotic tissue with a localized spongy tissue on maxillary anterior teeth, number 7, 8, and 9, and a generalized diffuse with a severe smooth, shiny, and erode texture. Radiographs present evidence of a localized furcation in posterior molar on number 2, 3, 14, 18, 19, and 30. This is like a this is the statement of the gingival assessment that I explained on the slide before. So it's the same thing that I already explained. This is some gingival picture that I took intraorally, and we can see the candidiasis infection in the buccal mucosa and the tongue, the generalized recession with generalized bleeding on probing, the recession with abrasion and erode texture, and also we can see the furcation class 2 and 3 on the posterior molars and the bright red color of the gingiva, and also the X-ray shows the severe of the periodontitis in the posterior region. On the periodontal shading, we can see the furcation and the mobility on the posterior region on the molars, and also we can see the generalized 4 to 6 millimeter pockets with a localized of 7 to 8 millimeter pockets in posteriors, and also the clinical attachment loss that vary from 5 to 8 of depth. On the periodontal classification, patient presents with generalized bleeding on probing and inflammation. Advanced signs of gingival attachment loss appear generalized with some localized furcation class 2 on teeth number 18 and 30, and mobility class 1 on teeth number 8 due to peri-implantitis and a generalized recession. In addition, evidence of furcation and mobility class 3 on teeth number 2, 3, 14, and 19. Radiographs present evidence of generalized horizontal and vertical bone loss with localized furcation on posterior and support the crestal bone changes from moderate to severe. The classification for this patient is plaque-induced gingivitis due to inadequate oral hygiene and generalized bleeding on probing, and also non-plaque-induced gingivitis due to lung cancer and stem cell transplant. Patient presents with generalized moderate chronic periodontitis on 66% of the dentition and a generalized severe chronic periodontitis on the other 44% of the dentition. Patient also presents a peri-implantitis on tooth number 8 and a herpetic lesion on the facial of 6 and 11, a localized mobility class 1 and 3 on teeth number 2, 3, 8, 14, and 19, and furcation involvement in teeth number 2, 3, 14, 18, 19, and 30. The ADA classification is what I already explained on previous slide for periodontal classification. The prognosis for this patient is questionable because patient has greater than 50% of attachment loss with root furcation class 2 and 3. The short-term goal for my patient is the use of chlorhexidine treatment for 2 weeks and the use of the water floss to eliminate the level of biofilm formation. My short-term goal as a clinician on appointment number 1 is a full mouth debridement and OHI with modified pass brushing and interdental brush technique explained. On appointment number 2, do an upper and lower left SRP with subgingival irrigation. On appointment number 3, do an upper and lower right SRP with subgingival irrigation and the use of a resin in both appointments. In number 2 and 3. The long-term goal for my patient is continue with good oral hygiene and improve his nutrition after do a nutritional counseling with him. And my short-term goal on appointment number 4 is do a perio maintenance of 6-week recall. On appointment number 5 is do a perio maintenance of 3-month recall and start doing every 3 months after that. Instruct in use of a soft toothbrush with a low abrasive toothbrush with the use of pass technique at least 2 times a day, use of an interdental brush and potentially super floss or at least once a day, and do a nutritional counseling. The modifiable factors are increased saliva, decreased bleeding, gingivitis, and inflammation with pseudo pockets, and non-modifiable are bone loss, mobility, furcation, loss of crestal lamina dura, and loss of the teeth. This, this was my treatment plan for appointment number 2. I started with reviewing medical history, taking vitals, pre-rinse with peri-dents. I did a comprehensive exam. I took an FMX digital, full mouth probing. I did a cancer screening. I did an extraoral and intraoral exam. I took intraoral picture. I took impression. I explained OHI and I started doing the nutritional counseling with my patient. I did the PI that was 80% at that time in the first appointment, and I did a full mouth debridement. On the second appointment, I start with reviewing medical history. I took vitals, pre-rinse with peri-dents. I did the PI that was 60%, so it was less than the first time. I applied topical anesthesia. I applied local anesthesia in left and upper and lower quadrant, doing an MSA, PSA, IA, and with lingual and buccal. I did an SRP in the upper and lower left quadrant using Caviton and hand scaling. I did a subgingival irrigation with chlorhexidine and I apply a resin in pockets of 5 millimeters or higher. I review and reinforce OSI and I start the nutritional counseling. On appointment number 3, I review medical history. Vitals were taken. Pre-rinse were given. I apply topical anesthesia. I apply local anesthesia in the right upper and lower quadrant. And I did MSA, PSA, IEA, and lingual and buccal. I did an SRP in the upper and lower right quadrant. I did subgingival irrigation with chlorhexidine. Apply a resin pockets of 5 millimeters or higher and reinforce OSI and nutritional analysis. On appointment number 4, I review medical history for any changes. I took vitals, pre-rinse with peridates. I did PI, which was 43% on the 4th appointment. I did a 6-week record perio maintenance, polishing, flossing. I improved OSI, and I did intraoral camera to see the progress of the patient from the first appointment to the 4th. On the 5th appointment, I review medical history again. Vitals were taken, pre-rinse were given, PI were updated, and it was 35%. I did a 3-month recall perio maintenance. I did irrigation, polishing, floss, fluoride, and evaluate OSI and enforce it. Also, I recheck nutritional counseling and patients state that the way he's eating now is better and helpful for him and his health. So after the 5th appointment, I start doing 3-month recall for him to continue the treatment and to see the progress. For home care recommendation, I gave him the use of chlorhexidine for rinse and also Clinpro 5000, which is an anti-cavity toothpaste because he had cavities before. However, he after the doctor exam and the referral, he went with a general dentist and he got all the cavities fixed. But I gave him the anti-cavity toothpaste for future cavities to prevent them. I also recommend tongue scraper. For the toothbrushing, I recommend Bass technique and also Charlotte technique when ulceration is present. I suggest him to change for a power toothbrush. For toothpaste, I suggest also sodium bicarbonate, such as Crest, Arm and Hammer, and also biotin toothpaste for decreased serostomia. Also, I suggest water flosser and use the at least once a day. Interdental floss and mouth rinses, I suggest biotin and chlorhexidine because I want to decrease the amount of microbiota on the oral cavity and also decrease serostomia. I suggest him to use high concentration of topical fluoride, like 6 times a year. And I recommend him to avoid any products that contain alcohol and prevent the use of toothpick that can produce ulceration in the gingiva. The nutritional analysis that I suggest him was add some cooked canned or frozen vegetable, also fruit and vegetable juices, eat antioxidant-rich food, including fruits such as blueberries, cherries, and tomatoes, and vegetables such as squash and bell pepper. Also, omega-3 rich seeds. I want him to omit from diet spicy herb or seasonings added to food after cooking, cold brew tea or sun tea, or boiled well water. And I want him to avoid alcohol or avoid food that is very hot or very cold. Avoid refined foods such as white bread, pasta, and sugar. Also, unpasteurized milk or yogurt, raw milk, eggnog made with raw eggs, and I suggest him to increase the amount of supplements of vitamin A, C, E, and D, omega 6, biotin, and vitamin B12. So this is my nutritional analysis for him to improve his health. This is my case study. I hope my patient can improve after following with me his treatment plan, and I suggest him to continue doing home care and using all my suggestions so he can improve his oral health and also his overall health. So this is all my case study, and I hope my patient continue improving, and thank you for listening.